Good morning. My name is Tess Nicholson and I am a third year nursing student at JCU, and myself, Zoe Davis, Ashley Andrews, Laura Fleming and Morgan Sleater are here to talk to you about drowning in children aged 1 to 3. In Australia, drowning is one of the leading causes of injury for children who are aged 1 to 3 years old. Today we will be conducting an in-service presentation surrounding some factors which are important to consider when caring for children who have been placed in this situation. We will discuss the anatomy and physiology of children aged 1 to 3. We will then highlight important strategies which can be used by health professionals in order to conduct a comprehensive health history, physical assessment, and pain assessment. We will also discuss the cognitive development of children in this age group and relate that to their decision-making abilities. Lastly, we will uncover some factors which may influence the high amount of drowning-related injuries which occur for children of this age group. There are numerous amounts of evident anatomical and physiological differences between pediatrics and adults. An obvious anatomical difference is children have large tongues and a small mouth, making them much more vulnerable to obstruction, whereas an adult's mouth is much more accommodating of their tongue. Due to a 1 to 3-year-old child still being in the very early stages of growth, their thoracic cage is extremely soft and their intercostal muscles are poorly developed. Therefore, they rely heavily on the diaphragm to create negative pressure and chest wall movement. An adult's chest wall is built with a strong thoracic cage and intercostal muscles. The larynx of a child has narrow cricoid cartilage and is of a funnel shape, which is another physiological difference when compared to adults. The gastrointestinal system of a child aged 1 to 3 years also distinguishes key anatomical and physiological differences. Children require increased fluid intake and nutritional requirements as they have a higher basal metabolic rate compared to adults. This also causes them to have increased waste production. The esophageal sphincter tone is lower in a child, which makes them more susceptible to regurgitation. A child's cardiovascular system differentiates a lot when compared to adults. Due to having a larger body surface area and losing fluid through evaporation, a child requires higher fluid intake to maintain adequate circulating volume. A child's myocytes are also much more immature, thinner, and a lot less compliant in comparison to an adult. Therefore, there is increased work for their cardiovascular system. Vital sign parameters differentiate greatly in pediatrics due to their anatomical and physiological variances. The younger a child is, the higher their normal values can reach due to their body system still developing. For children aged 1 to 2 years, their normal vital sign ranges are as follows: a respiratory rate of 25 to 35 breaths per minute, heart rate of 100 to 150 beats per minute, systolic blood pressure of 80 to 95 millimeters of mercury, temperature of 36 to 37 degrees, and oxygen saturations at 97 to 100%. Children of 3 years have slightly lower values, with their normal ranges being 25 to 35 breaths per minute for respiratory rate, 80 to 140 beats per minute for heart rate, a systolic blood pressure of 80 to 100 millimeters of mercury, and their temperature and oxygen saturations being the same, with 36 to 37 degrees and 97 to 100%. Children's normal respiratory rate values are considered high when contrasting to adults due to the minimal space they have to allow for gas exchange in their lungs. A faster heart rate is also obtained by children as they have a much faster basal metabolic rate, causing their cardiovascular system to work harder. There are many mechanisms that occur when a child's body is compensating during a time of illness. All systems of the body play a vital role to compensate accordingly when the body is fighting an illness or trauma. However, the respiratory, cardiovascular, and nervous systems generate apparent signs and symptoms that a children's body is responding. A child's work of breathing is an evident factor that their respiratory system is working harder than usual to compensate. Sternal, subcostal, or intercostal retraction and recession are indications of increased effort due to the respiratory system being compromised. Accessory muscle use, nasal flaring, head bobbing, and high respiratory rate are also evidential signs of increased work of breathing. It is compulsory for a child's cardiovascular system to assist in compensating as it involves one of the vital organs, the heart. During compensation, a child's blood pressure is commonly known to increase. The body is able to detect that not enough blood and oxygen is being received when it's unwell, therefore angiotensin and aldosterone is released, causing vasoconstriction and an increase in blood pressure. The body will also hold on to water and sodium, which increases the child's heart rate as it is attempting to compensate for poor blood circulation. An increase in heart rate and stroke volume is also a precursor that the body is compensating to maintain appropriate cardiac output. When a child's cardiac output is low, the body compensates by releasing adrenaline, stimulating the heart to beat faster. However, this mechanism can be counterproductive as the heart isn't given enough time to relax and refill effectively. As communication with a child of this age is limited due to lack of development, different strategies are required to obtain health histories for each different age group. Ages 1 to 3 in particular are very limited, therefore a parent or guardian that is aware of their health history should be the main person to gather this information from. Effective communication builds understanding and trust. When health professionals and parents understand and trust each other, they are able to work together to support children's well-being and development. This is why effective communication is key to establishing and maintaining a therapeutic relationship with the parents. An effective way to gather information from the parent or guardian can be done through the OPQRST method. Usually when a child is unwell, the parents will be concerned. Therefore, it is effective to have a guide on questions to ask to ensure that you have covered all aspects regarding the child's condition. Giving the parent or guardian a series of questions guided by this acronym makes it easier to focus on vital information that parents may not share if they were just asked one simple question. These communication styles are effective when communicating with parents and guardians to gain an understanding about the child's health history and condition while the child is between the ages of 1 and 3 years old and unable to effectively communicate on their own. Children aged 2 to 3 years old will be able to deliver small amounts of communication. Therefore, they should be given the opportunity to directly express their thoughts and feelings. Engage with the child using a soft, calm voice and use creative measures to interact with the child to find out more information. Assess their verbal cues such as crying, cooing, squealing, and language such as sore, ouch, and hurt. Assessment of nonverbal cues such as facial expression, eye contact, smiling, and grimacing will help to gain an understanding of what they're feeling. Acknowledge their gestures and body movements such as moving legs in excitement or distress and gestures. Simply asking them to point out where the pain is, for example, can give us a better understanding of what might be going on with our young patient. When the age group of 1 to 3 years old experiences pain, it can be hard as they cannot just communicate their pain to us. Pain is seen as the sixth vital sign, so we need to ensure that they are taking an accurate pain assessment and follow tools that allow us to effectively communicate with our patients. The Wong-Baker Pain Scale is an excellent tool to use to gauge a child's pain level when they are not able to communicate this information verbally. The Flack Pain Scale is also an effective scale to follow when identifying the level of pain a child is in. The Flack Pain Scale looks at face, legs, activity, cry, and consolability. The healthcare professional then rates from 0 to 2 with numerous descriptions in each section relating to each area of the body. Each category is then tallied and the final number enables us to discover how much pain the child is in. 0 indicates the child is relaxed and comfortable. 1 to 3 indicates the child is in mild discomfort. 4 to 6 indicates the child is in moderate pain. And 7 to 10 indicates the child is in severe discomfort and pain. Using tools like the Flack Pain Score and the Wong-Baker Pain Score allows for non-verbal communication of pain and therefore is a valid tool that ensures health professionals understand the pain that a child between the ages of 1 to 3 is experiencing. Hospitals can be daunting for adults, let alone small children, and dealing with strangers can often cause some distress for the child and their parents. Therefore, certain communication strategies need to be implemented in order to obtain the appropriate information while causing minimal stress to the child and their family. Strategies such as gathering as much data as possible through observation first. Use of the pediatric assessment tool, which is a rapid assessment to reduce and prevent agitation and upsetting the child. A health worker needs to assess their appearance, visualizing their tone, interaction, look, cry, speech, assess if they are consolable, their work of breathing, assessment of their respiratory rate, sounds, abnormal position, retraction, nasal flares, and circulation, so checking for any pallor, mottling, cyanosis, or bleeding. The position of the child, so they are as comfortable as possible, such as on their parent's lap instead of an exam table. Staying at the child's level as much as possible because towering over them may cause intimidation. The healthcare worker also needs to use an effective order of exam, performing the least distressing to the most distressing examination to ensure they stay calm for as much of the assessment as possible. Rapport with the child, include them and explain to the child's level as much as possible, making the interaction positive to build a relationship. Use distractions. This can keep the child occupied and happy. Research shows that distraction has a positive effect on children's distress behaviour. Examine the painful areas last to prevent upsetting the child, as this will negatively affect any following assessments that are still required. Be honest and warn them if something is going to hurt in a calm fashion. Surprising a pediatric patient with pain may ruin the trust and end their cooperation. Understand the developmental stages' impact on a child's response. For example, stranger anxiety is a normal stage of development, which may make examining a patient more difficult, and implementing the use of a reward system and playful interactions. The more distressed the children are during assessments, the more difficult it is to gather accurate information. Therefore, these strategies are a guide to ensure the child and parent are as comfortable as possible. Children's cognitive developmental stages are always evolving and developing, and their age group helps us to determine how the cognitive stages can influence the child's behaviour and decision making. The age of 1 more commonly uses gestures to communicate rather than words. They begin to understand what words mean and the action for them, but cannot always communicate it. Their autonomy is often expressed as defiant, and they mimic real-life situations in play. By the age of 2, they begin to identify hazards like a hot stove or a staircase. By 3, their vocabulary increases and they begin to communicate more with words and actions. They understand better with simple statements rather than complex statements. This makes it more difficult for the ages of 1 to 2 to understand how to make safe decisions on their own, as they do not understand boundaries and hazards. By the age of 3, they understand more of the dangers and how to express their feelings and emotions through words instead of crying or yelling. Piaget's theory of cognitive development supports this, as children's ages 0 to 2 are in the sensory motor stage, where they learn about the world through their senses, such as touch, taste, and smell. However, in the pre-operational stage, children begin to use words and symbols to represent their feelings and thoughts. When analysing these different age groups, it can be concluded that whatever cognitive stage they are up to in life influences the way in which the child behaves and their decision-making abilities. It has been found that drowning is one of the leading causes for injury among children aged 1 to 3 in Australia. In fact, this trend can be seen worldwide, as the highest drowning rates globally belong to this age group. In Australia, most of these cases occur in home swimming pools. However, children can also be at risk if they reside near other open water sources, such as ponds and ditches. 44% of these cases occur during the summer months in Australia. In order to prevent these incidents from occurring, it is important that parents and carers of children understand that the action of drowning can be very quick and completely silent. Often parents and carers are under the impression that they will hear a child if they are drowning, but this is not the case, as young children cannot lift themselves above the water once they are under. There are many actions which can help prevent this outcome, including ensuring children are always actively supervised around water, making sure pool gates are enclosed by a fence and the gate is closed, empty buckets and containers that contain water, establishing rules with the child to prevent them from going near the water without an adult present, teaching water awareness, learning how to resuscitate, and most importantly, patient and parent education. Today we have discussed information which is vital for healthcare workers to understand in relation to drowning, which is one of the main causes for injury for children aged 1 to 3 in Australia. One of the topics which was covered in this presentation includes the drastic difference in anatomic and physiological structure between children aged 1 to 3 and adults. We also discussed some useful strategies which can be implemented to gain a comprehensive health history and physical assessment. We have also discussed how the cognitive development of this age group influences their decision making. Lastly, we discussed some of the reasons as to why this is the leading cause of injury in this age group and some strategies which can be implemented in order to prevent these accidents from occurring. Thank you so much for watching.